Welcome, everybody. We're excited to be here. My name is Dr. Sarah Riley, and I'm the medical director of the STEP Clinic. Joining me today is Shannon Imetovski, who is our clinical director and who brings to us her expertise in nursing and public health. So today we're going to give an overview about how we approach the medical care of our patients at the STEP Clinic in order to promote overall health and wellness. So listed on this slide are the topics that we're going to delve into today and that we consider to be essential in maintaining overall health and wellness in our population. So they include the baseline health assessment and secondary psychosis workup, treatment of any comorbidities, and access to primary care, which links into our next point on preventative health, including screenings and vaccinations. We emphasize addressing any medication side effects early and aggressively in order to minimize reasons that someone might want to drop out of care. We educate on the basic tenets of living a healthy lifestyle, and we screen for substance use, including tobacco and alcohol, so that we can offer any interventions if the client is amenable. We pay close attention to sexual health, in particular the risk for pregnancy and STIs. So let's start with why we should care about the physical health of our patients. I think we all know that mental health and physical health are very closely interconnected, but for our population, the stakes are quite high. It's well documented in the literature that there's between a 10 and 20-year shortened life expectancy in individuals with schizophrenia and severe mental illness. And a recent meta-analysis in 2017 estimated that there are between 13 and 15 years of life lost in individuals with schizophrenia. Now, the reason for this is complex, it's multifaceted, but it includes things like higher rates of tobacco and other substance use, higher rates of sedentary behavior and poor nutrition, which are all risk factors for preventable illnesses like diabetes. There may also be an element of reduced help-seeking behavior, as well as an impact of social determinants of health in terms of access to care. And we know that our medications, unfortunately, confer metabolic risk as well. There's a higher suicide risk in our population, but I think it's important to mention that, this doesn't account for the reduction in life expectancy. Although it is a risk, our patients are 10 times more likely to die from cardiovascular disease than by suicide. As mentioned, there's an increased incidence of cardiovascular disease, as well as 2 to 3-fold increase in rates of obesity and diabetes. For years, it seemed like this gap was not only not reducing, but it was actually widening. And then a study came out in 2020 out of England that showed that implementation of existing interventions that target modifiable risk factors can actually close this gap between life expectancy in SMI patients than the general population. And we can close that gap possibly by 24% in men to 28% in women. Now, we still have a long way to go. And when we approach this with our patients, we want to be real about the metabolic risk. But we also really try to hold on to hope and convey our hope, because we believe that early in treatment, we can play a very critical role in empowering our patients to take control of their health and to minimize their long-term risks. So that's a really important aspect of our clinic. Now, whenever a new patient is admitted to our clinic, there's obviously a lot to learn about them, to teach, to do. Where do we start and how do we prioritize all this? We really believe in emphasizing from the first appointment that we care about the physical health of our patients. For some individuals, it can be easier at the beginning of treatment to talk about their physical health actually than their mental health. We try not to hide behind that or overly medicalize things, but at first they may have different ideas about why they're in treatment than we do, and we take a personalized approach. So if someone has an easier time talking about their physical health, we will hold on to that in an attempt to build rapport. We'll then do a medical record review if possible. We'll take an initial history so that we can understand, what problems they have that might need treatment. We will review hospital records, especially looking for any medical testing that has been done to identify gaps in the workup for secondary causes of psychosis, which I'll talk about next. We will also make sure that there are baseline labs, including a lipid panel and a hemoglobin A1C, so that we can monitor for development of any metabolic risk. We make sure that we have an initial set of vital signs on each of our patients, and that includes weight and height so that we can calculate a BMI. Our patients are mostly young and healthy, but they may have aged out of their pediatricians. And so some of our patients don't actually have a primary care provider. So at the first appointment, we'll ask if they need referral to primary care OBGYN, or any other referrals. And we're actually very lucky here at CMHC that we have a medical clinic within our building, which makes for coordinating care and collaborating on mutual patients quite easy. It's important to recognize that psychosis is a constellation of symptoms, as we know, that can have a variety of causes. Most of the people that we see in our clinic have psychosis that's caused by a schizophrenia spectrum illness or primary psychotic disorder. But we have to do due diligence to make sure that we're not missing a psychosis that's caused by a medical problem. As an example of this, someone who has, say, severe hypothyroidism might present with psychotic symptoms, but then when they're treated with synthetic thyroid hormone or levothyroxine, their psychotic symptoms would resolve. And so, in those patients, we wouldn't recommend long-term antipsychotic treatment. We wouldn't be the appropriate clinic, nor would I be the appropriate treater. So we want to make sure that we identify these cases so that they're treated appropriately. There's no standard recommendation in the literature for the workup of secondary causes of psychosis, and there's multiple sets of guidelines out there. So when we consider what we're going to test for, we think about several things, including the prevalence of the underlying illness we'd be trying to detect, the cost and invasiveness of the test, as well as properties like how we might interpret a positive or negative test result. We also think it's really important not to miss anything that could be easily treatable. So for example, HIV is a very easy serum test, and missing it could be quite devastating. With all of that in mind, we aim for the tests that are listed on this slide as a starting point to discuss with every patient. And there are many more tests that we can and do in some instances, depending on if a person has, specific historical elements or physical exam findings or abnormalities in this initial workup. Some of these tests, such as the complete blood count and complete metabolic panel, sort of serve a dual purpose of getting a basic health assessment on the patient, in addition to looking for things that would be causing psychosis. As an example, a CBC might reveal an anemia, and we wouldn't necessarily think that that's causally related to their psychosis, but important to treat because they'll feel a lot better. In addition to that, I mentioned already the hemoglobin A1C and the lipid panel, which serve as baseline values for anyone who's going to be started on an antipsychotic. So we can look for development of things like prediabetes or frank diabetes. I mentioned the thyroid hormone example. And then HIV and syphilis screens. Those are examples of things that we don't want to miss that are easily testable. We also like to get urine tox screen and a pregnancy test, as well as an EKG, which can look for prolonged QTC or something that will make our patients potentially more likely to develop an arrhythmia with certain medications. Head imaging is controversial in this field, because there's varying estimates on what the likelihood an abnormal result would be clinically significant for our patients. So we really believe that it should be offered to everybody, but followed by a discussion about risks and benefits. The choice should be individualized based on the patient's preferences. As I mentioned, if anything is abnormal initially, or if we have clinical suspicion that there's a medical problem going on, there's many more tests that we would do, but this is sort of the bare bones basic workup that we like to have offered to everybody. So offering antipsychotic medication is the standard of care for treatment of psychosis. For our purposes today, I just wanted to highlight that for the most part, the medications that we have to choose from initially are all very similar in efficacy. And what really varies is individual response as well as side effect profile. When we're starting to treat someone, we always take an individualized approach, and we want to think about what side effects might come up with a given agent and how they might affect that person's life, and take the patient's preferences into account in deciding on that first agent. For example, if someone is obese or has diabetes, we might choose a more weight neutral medication to begin with. And then, we pretty much across the board try to avoid Zyprexa as a first agent for folks, given that it's one of the worst offenders in terms of causing weight gain. Beyond just choosing that initial agent, we really believe in using the lowest effective dose for our patients to minimize the likelihood of any side effects. And sometimes when people come to us straight from the hospital, the first thing we do is often reduce the dose if they're experiencing any adverse effects that we think might be related. And this is, again, to make sure that we minimize any reasons that they might want to stop treatment. As another general principle, we try to minimize polypharmacy, antipsychotic polypharmacy, that is, because we know that each additional antipsychotic confers additional metabolic risk. And so if someone comes to us on, say, Abilify for their psychotic symptoms, but they also have a low dose of Seroquel on board with the indication for insomnia or sleep, one of the first things we would do is recommend replacing that Seroquel with something that's not an antipsychotic, like maybe trazodone or even melatonin, to lower the added metabolic risk that Seroquel would confer. We ask about side effects at every visit and take the patient's report seriously. If someone reports that they're having trouble with the medication, we have a very low threshold to reduce the dose or to switch agents entirely. So there's one specific side effect that deserves special mention in this talk. The rest I'll save for Dr. Srihari, but weight gain. So weight gain from antipsychotics is important to address because, as we've already mentioned, obesity is a huge contributor to the numerous diseases that confer shortened life expectancy in this population. And once weight is gained, it's really hard to lose. And we want to stay on top of this from the get-go and try to prevent it if we can. It's also important to note that weight gain is one of the first metabolic adverse effects of antipsychotic treatment. Far before we'll see changes in their blood work, the weight will creep up first and early in treatment. So how do we monitor this and stay on top of this? Ideally, we try to check weight weekly for the first 6 to 12 weeks after starting the medication, and then every 3 months. And now it's important to note that this isn't ideal. We don't get every patient in person every week, but we do strive for this so that we can really be on top of it. We'll then check a lipid panel and a hemoglobin A1C every 3 to 6 months. We do a lot of education on lifestyle interventions as a first-line treatment for weight gain. And in this population, it's really important to keep the messaging simple and start small. There's a ton of information out there. I'm sure many of us know from looking, you could really go into a rabbit hole of trying to figure out what the best diet or exercise regimen is to lose weight, but that can be very overwhelming and difficult. So we start small. One thing we might do is ask somebody how much soda they drink in a day and choose that as the first thing to try to target to cut back on or substitute with something else. In terms of exercise, again, we won't necessarily send someone to the gym to start an intense exercise regimen right away if they're not ready for that. So, we might start with recommending that they reduce sedentary time or maybe go for a walk around the house or the apartment, even to, between episodes of something they're watching, if they're watching a lot of TV, or, we really try to start by making it simple and feel doable so that they can have early success, and we'll build on that. We have a nutritionist that we refer people to, as well as there are groups that do various types of physical activity like a basketball group. And when talking about lifestyle interventions, one of the most important things to highlight is that we need to identify any barriers for our patients to, implementing these lifestyle changes. As an example, if someone is unstably housed or doesn't know how to cook or has low income and difficulty affording healthy foods, in our population being young, a lot of them have their family members cooking for them and may not be in total control of what the family is eating. So we want to figure out what's going on in the house for the patient before we, expect them to make these big changes. We want to try to target those barriers to treatment. We also want to validate how difficult it is and that we believe in the patients. We know this is hard work, but we are here with you as your team. From a medication perspective, we might switch to a more weight neutral agent. We might add metformin. And then many patients are now asking about Ozempic and other GLP-1 agonists, which, some patients are having a lot of success with. In general, for those requests, we are referring to primary care, just given that they're more experienced with, dealing with the prior auths for those medications and knowing the nuances of which drugs are available, given all the shortages, and which drugs might be lower cost. As we know, there's a higher rates across the board of substance use in this population, so it's important to screen for substance use in a non-judgmental and non-stigmatizing way. Smoking cigarettes or vaping, is an important contributor to cardiac risk and other preventable illnesses. So we think it's important to ask about how much someone is smoking, what they are smoking, and then kind of assess readiness to quit or cut back. So what I'll tell everybody is, I'm not putting pressure on you and I'm not going to give you a lecture, but if you are interested in quitting or cutting back, it's the best thing you can do for your overall health, and I'm here to help. I can prescribe medications or other interventions and work with you. And you can always come back later. If you're not ready now, we're here and we want to help. Try to make it low pressure, but if there is interest in quitting, it's important to really capitalize on that when the person is there and ready. It's important, as we know, to screen for alcohol, cannabis, and other substances. We talk to everybody about the association between cannabis use and psychotic symptoms. Again, trying not to lecture and to be non-judgmental, but with the goal of really assessing where someone's at in terms of any readiness to quit. If someone's not ready to quit, that's fine, and we'll work with them and use a harm reduction approach. So an example of this is, maybe offering or recommending that they get their cannabis from the dispensary instead of from the streets. Maybe recommending that they use a strain with lower percentage of THC. We might prescribe Narcan, even if someone doesn't, state that they're using opiates. Just in case there's contamination, and we'll educate on that. And then we have fentanyl test strips that we can give to our patients along with that education. As I mentioned before, we really make sure that everybody has primary care physician, even if they're healthy and they don't have any comorbidities, just because things come up in the course of treatment, like weight gain, metabolic risk, but other side effects or other non-related, health issues that we want to help empower them to stay on top of. Primary care physicians can also help us refer to specialists if someone needs, for example, a sleep clinic referral. A lot of times it's easier to get them in if it's coming from the primary care. So in our young patients, sexual health is a priority. We ask about last menstrual period, sexual activity, partners, risky sexual behavior, use of contraception. And if a pregnancy is not desired, we want to make sure that someone has the option to be referred to start birth control. We also have access to condoms that we give out at the nursing station at the second floor that we direct people to. And anyone on medications, we really feel like it's important to talk to them about what the effect of their medication may be on a potential unplanned pregnancy. And again, think about individualized prescribing in that regard. So for example, someone of, a woman of reproductive age who is sexually active without contraception, I would not prescribe Depakote as an example. Just try to keep that in the back of our minds at all times. Keeping in line with our kind of focus overall on health, we offer everybody STI screenings. We also screen for safety in the home and intimate partner violence. This is important to know about. In routine clinical care, it's very easy for time to get away from us, as we know. Before you know it, you could be working with someone for a year and kind of things are status quo. So one of the ways that we've implemented in the STEP clinic to kind of try to combat this and get us to be very intentional in thinking through our patients and providing the best care is this 3-month formulation. And this is the MD on the case will review all the medical history, and we'll write up kind of a current formulation as well as an identification of all the current problems that someone might be having or that might be a barrier to recovery. And then we will have a multidisciplinary team discussion on all of this and think about ways that we could be better engaging with this patient or maybe better handling any early side effects. At this point, we usually expect that most of the medical workup has been done or at least offered. And so this is sort of a checkpoint for that too, to make sure that we're not missing anything early in treatment. We'll also compare the baseline weight to the current weight at the 3-month point, since that, as I mentioned, early in treatment is generally when a lot of the weight gain can happen. And I've been humbled and surprised at sort of some of the early weight gain that has crept in that I didn't really notice, just seeing the person week to week. But then when I sat down to do the 3-month formulation and really compared the numbers, it's been striking. And so for us, this has been a helpful way to kind of make sure we're staying on top of all the various things that we feel responsible for. And I find it personally very, very helpful to review patients at the 3-month point, just to make sure that I am being as thorough as possible. We know this isn't a practical approach for every clinic out there, but we're hoping that this is something that improves our care and our outcomes. And with that, I turn it over to Shannon for the next portion of the talk. I really appreciate your attention. Thank you.
Hi, everyone. Thanks for joining us. So I'm going to talk more about like the clinician role. My background is in nursing, but I think what I'm talking about applies to social work or any other discipline where you're more frequently kind of meeting with clients. So like Dr. Riley said, I think from the get-go on admission to our clinic, we really try to normalize the connection between physical and mental health. And sometimes it's a little bit odd for a clinician to kind of be talking about this stuff. Sometimes it's more reserved for that MD role. In our clinic, we really try to, let people know that we're going to be talking about it, even as social workers or nurses that might not have background in it. That way, the patient kind of feels really comfortable talking about it. And so one of the things is just like regular monitoring. As a clinician, you're going to see the clients probably way more than the MD does. So you're going to be knowing more about their lives, their lifestyle, what they're eating, if they're exercising and all that kind of stuff. So we try to track some of that stuff really regularly. So obviously on admission, we'll get like a weight, but as clinicians, we've all kind of put scales in our office to make it really normal that we'll just kind of weigh people as much as we can, really, especially when folks first get to us, because that tends to be the time a lot of people are on an antipsychotic for the first time where they'll gain a lot of weight. We try to keep really close track of it in the beginning and really on an ongoing measure, just kind of when you go to the primary care doctor, you kind of step on the scale. That's kind of the first thing you do. And then that feels a little bit different in a mental health clinic. We try to make it kind of just the same sort of practice. And like I said, we're going to be talking probably about sexual behaviors, substance use, what they're eating, what they're drinking, kind of on a routine basis. Just what are you eating these days? Are you eating enough? Are those healthy choices? Because like I said, we'll be talking about that stuff. Around that, we'll be setting some goals. So if someone does identify or we suggest maybe, is there a way that maybe you want to eat healthier, maybe you want to move a little bit more, we're going to be working with them to kind of set up some goals and to track that progress. So they'll come in, sometimes it's part of the treatment plan. Other times it's just kind of ad hoc, like someone will come in and say, maybe they'll get a weight and say, oof, I don't really like that number. I'm feeling like maybe I want to move more. So we'll kind of sit down and talk about, okay, well, again, right back to what Dr. Riley said, what are some small changes that we can really start with? So let's pick one thing. Let's set a really reasonable goal for the next week or two, check in on it. That way, try to build some positive change. Nothing, and I'm always telling clients, you're not going to lose 30 pounds in 2 weeks like we would all like to with a snap of a finger. It's going to be these small changes, a couple pounds every week, and hopefully build some positive momentum. Same with like smoking or substance use. And you know what? It's all hard. Sometimes people have a little bit of buy-in that obviously fluctuates week to week, month to month. And so part of the goal of the clinician is to address those barriers. So, do you want to quit smoking now? Okay, maybe not, but let's keep checking in on it because the person has to have a little bit of buy-in. We can't force someone to start eating salads every day if there's no buy-in. Trying to meet those goals, we'll also be talking about like connecting them with other resources. So we can do a lot in session, but there's a lot of things we can't do. And so at CMHC, we're lucky to have some connection with some good resources. So we have a nutritionist in-house, but that's something that's very easily available in the community. There's local clinics that do it. Some primary care doctors can connect people with nutritionists. So there's a lot of other disciplines that we can kind of bring in once someone is kind of ready to make some of those changes. We're also, because it's in a therapy session, we're going to be using many different modalities to try to talk about it around goal setting, what the barriers are. So maybe CBT, some MI, and other different approaches. You're going to get to know what works for the client, right? Part of the big thing is just having an alliance, getting to know the person, getting familiar with them so that it is maybe more comfortable to kind of point out like, hey, like maybe you're not moving a lot. And so they'll kind of trust you to like say that and kind of talk about it. But there has to be a basis there where they're coming in and talking, which is the hardest part of the game, honestly. So, and that's an ongoing process. But I think that's one of the most important parts to try to get some buy-in with folks. Again, you're going to also be coordinating a lot, especially with the MD around these things. If there's something that comes up in a session, because you'll see them more frequently, feeding it back to the MD as soon as possible, pulling them in as needed. We're super lucky at STEP that our MDs are like super flexible and available, so we can pull them in kind of as needed. We don't have to wait weeks or months to pull them in. And I know that's not always the case, but to address things sooner rather than later. Like Dr. Riley said, things like sneak up on us. So like you see the client week after week, maybe you're not doing as good a job as tracking, and then all of a sudden they're up 30 pounds and you're like, oh my goodness. And so pulling the MD in as soon as possible to kind of work through some of that. Also, promoting some of these healthy habits in session if possible. So one of the things that we really like to do, if possible, is to like incorporate walking during a session. When the weather is nice, let's go outside, let's take a couple laps around the building, let's, just to kind of promote those behaviors. I've started to have some snacks in my office. Usually they're healthy, not all the time, because I do get requests for some people that are not super healthy, but I try to do a mix of things, to get people to come in the door, but also then like maybe a granola bar instead of a bag of chips. So I think that can go a long way. Snacks actually are one of the things that people come in for, not to talk to me, but just to have the snacks, and they'll eat them during session. But it's really nice to walk because it's nice to get fresh air. And sometimes that's the only movement that people will get initially. They're not maybe getting out that much. They're not going to a gym, but to just show them like, look how easy this is to just kind of like take a walk around the building. And people really like it. And it's an excuse for us to get out of our office. So I'm always happy to be the one to do that. During colder months, back in the day, we haven't used this too frequently recently, but we do have a gym in our building as well. So even like going downstairs and maybe walking on a treadmill or, anything to kind of promote that. Because I think all of us know it's hard to walk in a gym for the first time, or it's hard to start an exercise program. So having the support of your clinician or someone else to help you get over that initial hump can be really great. We can go to the next slide. And like I said, I think there's a lot of other disciplines that people can pull in, as available. I'm a nurse. I think, that makes sense. They can do the tracking sometimes if someone's really uncomfortable or there's other barriers as to maybe why the clinician wouldn't be the one doing the tracking, and we can think about maybe it's uncomfortable. Maybe someone's had a history of an eating disorder or other things where it just makes that feel a little bit kind of uncomfortable. Maybe pulling in the nurse to do it because that's what they do to kind of take that burden off of the clinician. Like I said, we have nutritionists, and I think those are readily available through different channels in the community. The other thing that we've kind of played around with is using OT to kind of promote healthy behaviors. So they can do things and they can get really creative. One of the things that we've kind of thought about is they can maybe take someone to the grocery store to figure out like maybe some healthy ways to shop. So some people will, if they've never grocery shopped before, especially a lot of people are on a budget, they're getting SNAP benefits. Okay, how can we make this go a long way? And it's how to read a nutrition label, kind of just basic skills that can really kind of set someone up for making healthier choices down the line. OTs are also, they can run groups, they can, help with like access to a gym. I think they have like a lot of different functions that can be really helpful. Case managers, I think in the same vein, they could also figure out, okay, how do we get to the gym? Let's talk about maybe even riding the bus. Like you don't know how to do that. What's the route to get to the gym? What's the route to get to the community center? Here's a local park where there's a walking trail. I think sometimes people don't even really know where to start, and it can be really basic, but it's kind of just getting the support to kind of figure out those things. Peers would be a really great resource to kind of tap to do some of this stuff if available in your clinic. And that makes it a little less formal, right? It's really nice to have someone who's kind of one is like checking in just to see how someone's doing, but also can go along with like promoting healthier habits. Sometimes, people don't have kind of role models in their community or in their support system that like kind of can model this stuff. So bringing other people in to do it is sometimes really great. Part of what we're doing at STEP right now is actually trying to do a little bit of research about what are the community resources available kind of in our catchment. So, gyms they cost money. Some are low cost, but sometimes that's even too much for clients or families to afford. So just in the kind of basic early phase that we've been doing, we've been looking at kind of community centers where maybe it's $50 for the whole year for someone to access the gym. There's a community center right in New Haven that has a free gym available. There's groups that are kind of exercise-based through our organization, which, I think is common. But sometimes people don't want to do that, right? They're young folks. It's hard to even get them through the door for sessions sometimes. And to be identified as someone who seeks services through a mental health agency, they want that limited to that and maybe not to come and do a basketball group or do a walking group. They just kind of want to be in the community and like normal teenagers and young adults. So a gym might feel more comfortable. So finding out those resources, I was looking at like community gardens where they can kind of participate and also go home with fresh fruits and veggies, and finding local farmers markets where if they have SNAP, their dollars can be doubled. Like things where they can be out in the community, do their thing, but also access these kind of healthy things. So those are just some of the things that we can kind of coordinate with. Like Dr. Riley said, we're looking at kind of referring people maybe to weight loss or obesity clinic to coordinate, and also definitely coordinating with primary care. That can be a huge resource. They have access to other things. They know a lot more than probably we do about some health interventions, but sometimes it's good to coordinate with them. The other thing is like utilizing the person's supports, because our folks are usually are really young and often living with family members. It's really helpful to kind of include their supports in their goal setting and in their kind of health and wellness stuff. And usually it starts with education. I think oftentimes people don't have an educational background about nutrition. Like they don't really teach that a lot in school. So like people might not know calories and, protein, like what should I be eating and what do I have access to? I think it's hard too with, there's not as many healthy supermarkets around. So maybe what can you get from a corner store that's like maybe a better choice than what you've been choosing. But that takes a whole system. If someone else is doing the grocery shopping, which is usually the case for a lot of young folks, maybe you can sit down with your parents and figure out like, okay, is there a couple items that maybe you can add to the weekly shopping list? But usually it's helpful to bring those supports or parents or family members in to have that conversation. And usually when we're like referring to the nutritionist, she'll ask like, can we include the family? Because it's really hard to make changes with one person if they're kind of existing in this system. And we really, our new goal is really to try to get this information into the hands of families and clients as early as possible. We find that, we get a lot of our admissions from the hospital, and unfortunately, their time is limited, but they'll come to us and maybe not know that there's risks of weight gain associated with the medication they're on. And so we kind of, we'd really like to give them that information, not to scare them to say, oh my God, don't take this med, but to just be really mindful of, this may affect what you want to eat, your ability to lose weight, if you gain weight. And so it's good for people to have that information so that they can adjust accordingly, and for families to know. And so that not all of a sudden they wake up and, their young person has gained a significant amount of weight. And that's super distressing, not only for the client, but also for the family to see. And it's good to have supports kind of in your goal, right? Oftentimes it's nice to have maybe mom, dad, whoever is like, okay, well, let's go out and walk together, or let's go to the gym together. It's always good to have a buddy to go along with. I find that I'm much more accountable to things if someone else knows my goal or someone else is maybe gently reminding me. Really want to encourage people to have it be like an encouraging and not a punitive sort of thing. I've seen bad circumstances where families can be really hard on young people. They're not doing anything, they're not moving. And so part of the education is also telling them ongoing symptoms, negative symptoms can affect people's motivation, wanting to do things. So to try to be encouraged, like, let's get up and do something really small together and not feel like, they're pulling out their hair, this person won't get out of bed, and it just becomes this bigger issue at home. Families can also be helpful in getting people in here, getting people to get, routine labs like Dr. Riley talked about. The more we interface with families, I think it opens up the lines of communication. So if they're seeing some concerning health behaviors, whether it's around diet, exercise, sexual behavior, substance use, they can reach out to us to just say, kind of worried about this. This is what I'm seeing at home. I think the more collateral information we have around, anything is really helpful. We get to see the clients an hour a week. It's very limited in what we know oftentimes. And so, support systems can be really helpful in giving us this information. It's not an easy thing to talk about. It's not an easy thing to make change with. I think, we're always trying to improve upon our practices. I think sometimes, like Dr. Riley said, it kind of sneaks up on us. There's so many fires to put out when someone gets to us sometimes. They've just gone through either hospitalization or this really big change, and there's so much going on that this stuff can kind of get lost in the shuffle. And so we're really trying to prioritize it. So it's just because it is just as important as everything else. But sometimes it's like this thing in our face and we're the mental health provider, so we should deal with this first. But we really want to try to kind of equalize it so that we're dealing with the whole person. It's a work in progress. We're always looking for new ways to kind of incorporate interventions and talking about it. But it's something that it's super important. And I think we're trying to get a little bit better at just talking talking about it in session, and all of my clients are pretty receptive. You know, there's certain definitely ongoing barriers to get people to change and do things, but I think the more you talk about it, I feel sometimes people are then more willing to like do something about it. Yeah, that's all I have to say about the clinician role. But I appreciate everyone. I don't think there's another slide. Yeah, everyone coming today and listening to us. And I think we have some announcements before we close today.
Great. Thank you so much, Sarah and Shannon. That was a wonderful presentation and such a, like you said, an important topic that sometimes does get lost in the shuffle. So we wanted to share some announcements from the Learning Collaborative. This is our remaining schedule for the training series. Some exciting offerings that we have. They're targeted towards family and community members. And so we have a new workshop series that'll be starting this month, and it'll run on the third Thursday of the month at the same time, 12 o'clock on Zoom. And then we're really excited to offer an additional 3-part series where we're talking about concrete strategies for families. And so although these workshops here are oriented towards family and community members, we encourage any providers who are interested to come. We will be able to also offer CMEs. And so if you're someone who might be working with a family who has a young person with early psychosis, particularly the strategy sessions, I think would be really beneficial to help you also kind of bolster your skills in supporting family members about how to work through some of these communication skills and general family guidelines in order to best support a young person. Thank you all so much. We really appreciate it. If you have any questions, we encourage you to fill out the really quick and easy form for our consultation survey. You'll be able to kind of get any questions answered, whether it's a kind of a general question about treating someone with early psychosis or a specific question about an individual that you're working with. We're able to utilize our kind of expert clinicians and prescribers and other folks associated with STEP to staff this consultation line.